So I'm going to teach you guys what this is later. This is a really cool picture that my assistant took after one of our surgeries. So you'll stay tuned and find out about that. So we're going to talk about what is biological dentistry. We're going to talk about the three main health killers that we like to refer to. These are metals in the mouth, root canals, cavitations, and then we're going to touch on neuromuscular dentistry at the end. As you guys know, I'm Julian. I graduated dental school in 2015, and I was practicing conventional dentistry up until around 2022. And my wheels started spinning, and I started going down the health rabbit hole, which was provoked by the whole COVID shenanigans. and then I got to a point where I could no longer ignore. You know what? I'm recording this for everyone in case anyone missed it, but yeah, I could no longer ignore what I was doing in dentistry and how it was connected to the patient's health. And I had to start examining everything I was doing and reevaluating everything. I kind of had a dark night of the soul, and actually many of them, and reevaluated my whole life. And I actually reached a point where I didn't know if I was going to be able to practice dentistry anymore, because what I was doing was just not aligned with my feelings about health, and I'm not someone that can just do something for money, right? So anyway, I met this guy. I went to his course in the fall of 2022, and I was looking into ceramic implants for a few years, and I was planning on going to courses on it. COVID kind of shut all that down, and then I was just seeing if the courses were starting again, and I went to this one in Tampa and met Dr. Volz. So Dr. Volz is a surgeon who's head of the Swiss Biohealth Clinic. It's a very famous clinic in Switzerland. Some of you here might know Dr. Dietrich Klinghardt. So him and Dr. Volz are partnered in this medical dental clinic. So I went to his course to learn about what he was doing. I was skeptical going, and then afterwards I was super convinced, and he's like 60 years old. He's the picture of health. So when you go to dental courses, like most dentists aren't the most impressive looking people. And like that's kind of, I went to so many dental courses.
There's a few exceptions in the room.
Yeah, I mean, yeah, just like I would go to these courses with these gurus in dentistry that do this amazing work, and they have these beautiful social media platforms with all these incredible dental cases they've done. And the thing that was always missing was the health connection. They had no eye for the patient's health at all. You know, even they would be talking about the breathing and airway problems, and first thing they would do, take out the tonsils, take out the adenoids. Like, it was very kind of butcher type of approach. And I'm like, did you try to take them off dairy first before you took out the, you know, like, so I never really jived with that conventional dentistry. When I met this guy, I was like, okay, this guy, I'm aligned with this guy. He lives it. He doesn't just teach it. So then he said to me, I had a root canal on my front tooth, and he said to me, I went and asked him what should I do with my root canal, because I was thinking about getting it out. And he said, if you come to my course in Switzerland, I'll do your tooth for you as the demo, the live demo, in front of all the dentists in the course. So then I was like, I'm going to take you up on that. So then I went. It was like 6 months later, and then I had the surgery done, went through the experience as the patient, and then afterwards I was like, I made up my mind. I was like, this is what I'm going to do. I'm going to change everything I'm doing. And kind of 2 years later, we're literally like 2 years later to the date almost, and the last 2 years has been a real transformation for me. So then I met this guy, Dr. Dominik Nischwitz, and he teaches a lot of these concepts on a more advanced level. And so I started doing his training. I went to his clinic in September last year. I brought Dr. Clinton and Alex with me, and we did Dr. Clinton's full mouth surgery while we were there. And then I've been implementing all of his concepts, and it's been amazing having him as a mentor. So biological dentistry. I'm just going to read this for you. So a biological dentist looks beyond the mouth when considering the best treatment options for their patients. Biological dentistry is the marriage between oral medicine and functional medicine and considers how the state of the mouth and the various treatment options available may impact the overall well-being of the patient. As a biological dentist, you no longer have to sit and watch your patient's condition deteriorate as the years go on. Instead, you can help them with the remediation of oral toxicity and infection and ultimately help them along their journey to optimal health. So this is where we need you guys. So like I'm pretty limited. I can do a lot in the mouth, but then I'm kind of out of tools after that, right? So I work with a lot of patients. Patients find me and they know the Dental Connection. Like the way patients find me is because they haven't been able to get help from the medical system, and then they get on some rabbit hole, they find out about biological dentistry, and then they find me. And then I'm sitting there with them listening to their problems and everything, and then we talk about some treatment. And a lot of them, I know that I can't make them better. I need people like you who understand all the complex systems of the body, and then we can work together to help these people heal. So that's really like the purpose of tonight. I'm trying to give you guys some things that you can be on the lookout for and aware of that might be going on in your patients and a reason why they're not getting better. And then we need you for a whole bunch of other things, like specifically detoxification, right? So we take out all these sources of toxicity in the mouth, but a lot of patients, they're not functioning well. Their drainage pathways aren't working. And so we take out all the toxins and they still don't get better because they're not flushing things out properly, right? So there's a lot of collaboration that's needed between both of our teams here. So this really, I love this video. This really
It's just, there's all this pressure.
hits the point.
And sometimes it feels like it's right up on me. And I can just feel it, like literally feel it in my head. And it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. I'm not sleeping very well at all, and all my sweaters are snagged, I mean, all of them.
Sounds really hard.
Ow!
Come on. If you would just.
Don't,
So it's funny, but it's actually what a lot of you are dealing with. So you're sitting across. I came and shadowed Dr. Arsenault for a day, and I sat across the desk and I watched the interaction with the patient, and this is actually going on. So this could be going on in your patient's mouth, and you're trying to help them with some of their health problems, and they've got nails all in their mouth, and so. You've got this symptom, that symptom, and you've got a problem. You've got a source of all this toxicity and all these foreign things that could be in their mouth that's been done to them by the dentist over the decades. And that's kind of what this presentation is about. So I hope you enjoyed that little anecdote or that little story there. So my question is, like, if someone's mouth looks like this, do you think this could maybe lead to them experiencing some health problems? So this guy is a family friend, and he was my dad's patient for years, and my dad actually fixed him up. He had a lot of botched dentistry. He's got 11 root canals in his mouth. So each one of this is a normal nerve, and then each one of these where you see the white filling material in the tooth, that's a root canal. So that's a dead tooth. That's the nerve's been filed out of in order for the patient to keep the tooth, to keep it for biting and for their smile. The tooth's been kind of embalmed and preserved in their mouth. And I'm going to show you what some of these things look like when we take them out. Here is another crazy example. So this is a thing that gets done in dentistry where someone's lost all their teeth, and then we put in implants, which are screws in the jaw. I did tons of this kind of work before I got into the biological stuff. And then you've got a set of porcelain teeth kind of screwed into the implants, and someone's got a new set of teeth screwed into their mouth, and this is not supposed to come out. This person's came out. So this patient kind of didn't come to the dentist for a while, and then they came into the office one day with this set of teeth in their hand, and you can see where the implants were, and it was such a sort, like we're talking about inflammation. You think this is a small source of inflammation, right? So those are titanium implants on the right, and you can actually see the corrosion. So they actually rust. So these fixtures in the mouth are prone to rusting. And the way I look at this now is, the way conventional dentistry would look at this is, oh, this patient didn't do their maintenance. They didn't come for their cleanings, and they didn't keep it clean. And like, yeah, you have to come in every 6 months and get this removed, and we'll clean in there, and we've got to maintain this. I look at this now and I go, no, their body didn't want that in there. Their body pushed it out. It took a while. And they've got the same thing on the upper, which it's not as severe, but it's kind of heading in that direction too. So we always look for like how much bone loss is there around the implants. But yeah, that's the nail, right? So that's the video. This person had all this inflammation, probably all these symptoms. And then finally the body was able to push it out, and their body's probably a lot happier now. Yeah. Okay, so let's just quickly go through some of these things. So these are some of the different metals that can be put in a patient's mouth. So we all know about amalgam, which is 50% mercury. That's the silver filling. So that picture there, you can see the mercury amalgam fillings. We use titanium for dental implants. We use gold. We use stainless steel. A lot of people probably in this room have one of those lingual bars after orthodontic treatment. Kelly's got them. Mel's got them. Yeah. So chromium, cobalt. There's all kinds of different metals used in dentistry. And part of the problem with metals is you guys don't need to be told this, the toxicity that can be caused by metals in a patient, the corrosion, which is what we talked about. Then there's the electrical phenomena. So there's the whole concept and topic of EMFs, right? So Wi-Fi and 4G, 5G. You've got these metal fixtures in your mouth now, which act as antennas. And so we already are exposed to enough of these wireless frequencies. Now you've got something that is pulling in more of them right near your brain, and it's amplifying. So there's even some studies that show that if you have one of these metal implants and you take a cell phone call, the bone around the implant heats up. And then we get a lot of bone necrosis around dental implants now too. So yeah, that's the EMF's antenna. And then the metals can actually affect the nervous system too, because as you guys know, we're electrical beings, and metals interfere with our body's electrical system. There's this process that can happen called galvanic corrosion. This is in your notes, so I'm not going to read this, but basically anyone who took physics or chemistry would know this, but then in dentistry we're not taught this. So when you have two metals that are different, so it's called dissimilar metals, and you connect them in solution, so like saliva, then like a galvanic cell is formed, and electrons flow from one metal to the other, and it creates like a battery. And so you can get this process called galvanic corrosion, and you actually see the corrosive process happening on the metals. And at the same time, metals are being leached into the body systemically. And yeah, I think that's mostly it on that topic. But yeah, if you want to read more detail, I put a link there for you. So this is something, we don't learn this in dental school. They just teach us about the dental materials we can use and for different mechanical purposes, but the chemistry is ignored, and this could be something that's affecting a patient's health. So where am I here? So there's some precautions and protocols that can be, Rob loves this. Yeah, I know, that's what they want you to do. Yeah. So the removal of metals in the mouth is something that needs to be taken, careful attention needs to be paid to, because let's say it's the mercury, for example, in the tooth. There's a small amount of mercury that gets leached out day to day from a mercury filling. When you go drill it out as the dentist, you release everything. So there's protocols to safely remove metals from a patient's mouth to protect them, and also some things to protect you, the clinician. And so there's this SMART protocol from the IAOMT that's like a certification and a whole protocol to follow for safe metal removal. So that's something that we're doing. There's a whole other conversation to have about, like, everything I'm going to present to you guys today. I'm not meaning to like fearmonger or like scare anyone if people have these things. There's a whole conversation about whether or not it's beneficial to remove all the mercury fillings. Dr. Clinton's kind of took me to school on that one too. So you can test if a patient's clearing mercury properly. There's something called the Quicksilver test. And so when we're working with these patients that might have metal toxicity or something, we can lean on some labs to help inform our decision making. So I'm not sitting here saying like everyone needs to have all their stuff removed. You work on a patient by patient basis. The way I look at it is, if someone's really struggling with their health and they're not getting better, then it really makes a good case to look to the mouth and see what kind of interventions we can do. Nothing comes without risk, right? Like if you do this, if you decide to drill out the mercury fillings, you always damage the tooth without fail. And so the patient's got to accept the risk that they might lose the tooth. I have to drill your tooth. There could be some negative consequences. One of those could be the tooth's not restorable, or you need a root canal or something like that, right? So there's a lot of nuance to these discussions. Now I'm going to share a case. So some of you might know this patient, Larry Harding. Is that his last name?
Is that the
Larry.
collaborator one?
Yeah. Yeah, Larry Harding. Yeah. So Larry is 69. He's got non-Hodgkin's lymphoma, and he's going through that. And he's kind of a holistic guy, so he's trying to make things cleaner in his mouth and hope that it helps his condition. So he's got a bunch of titanium implants. He's also got some ceramic implants, which I'll teach you guys about. So he's got 2 ceramic implants that were done by another dentist. And then he's got 7 titanium implants. The upper left, so that's upper right the way you're looking at it. That's his upper left. That one was really bad, and he had a practitioner doing ART, like the muscle testing and all that stuff, who told him, hey, that upper left, you need to deal with that, and like it's the problem. So anyway, that's what we started with. I just want to present a possible connection here to his disease. So the titanium implants, they are alloys. They're not pure titanium, and pure titanium doesn't have the right mechanical characteristics that you would need for strength. So they make the implants alloys. They've got usually aluminum, vanadium, sometimes nickel. So there's a variety of different metals that these implants can be made of. And that's one of the reasons we see this inflammation around them, because we all know those women that can't wear certain jewelry and they get a reaction. This is the same thing that goes on in the mouth when you have these alloys. This is a study that put titanium implants in dogs, and then they tested the regional lymph nodes and found titanium particles in the lymph nodes. So the implants, through the mechanical wear on them, they release particles of titanium, and then those can spread systemically. So that's a possible sort of pathway how this patient maybe got the lymphoma, the non-Hodgkin's lymphoma. I can't be sure of any of this stuff, but it's a possible link. So this is what we do when we come up with a treatment plan. We do a diagram here on their panoramic x-ray, and we put in digital versions of the implants and then kind of do our treatment proposal. And then this is also we print it out, put it on the wall, and then when I do someone's full mouth surgery, it's kind of my map of what the plan is. So we started on the left side. You can see his implants here. And then I have a video. Is it going to come?
Okay.
Yeah.
So the one, can you go back?
Yeah.
Back one more?
Yeah.
The one on the right, see how it's red? Is that supposed to be
Over there.
that red? Is that normal?
Well, this is more normal, and that one's inflamed.
Okay, so that is inflamed.
Yeah. Oh, yeah.
That-
Yeah.
I didn't-
And then this is when some of these will get a little bit gory, but you guys can handle it, your doctors. This is what it looked like just from me reflecting the gum tissue. So I haven't removed any bone or anything here. So you can see there's all this bone loss around that implant, and the threads are exposed. And that's been a progressive process over time. These wouldn't have looked like this when they put the implant in. They would have gone fully into bone, but then there was an inflammation, chronic inflammation there, and it results in destruction of the tissue. Kind of like the one I showed you at the beginning where the whole thing came out. It's just a more mild version of that. And so I go and I take them out. And again, I'm not taking these out of every patient, but this guy's got serious health concerns. So you throw the book at them, because he's not gonna live if we don't do something, right? This is after the implants are out. So this is an ultrasonic scaling device. And so once I have the implants out, I use this a lot, and this is how I clean the bone. So I keep cleaning and cleaning until I'm only left with healthy bone, and I'm removing all of the granulation tissue and all of the scar tissue. And so this is what a lot of the surgery is, the time spent is cleaning bone. Yeah. And they don't teach this when you learn to do dental implants and stuff. I learned this from the two guys I showed you at the beginning. Anyway, sorry for that horrendous noise. Yeah. Okay, so then once everything's cleaned out, then we can go and we can put new implants in right away. So these are the ceramic implants, and we can put them usually right back into the same position that the titanium ones were in. So this is what we did with Dr. Clinton too in Germany. Okay, so just to show a little bit of that, there's immediately, like at the end of the surgery, there's everything sutured up. And then we did the right side. So you can kind of see the evolution from the pre-op to the plan, and then this is the post-op. So now he's got no more titanium implants, and eventually we'll attach his teeth to them after 4 months. Let's talk about root canals now. So this is the guy that I showed at the beginning with the 11 root canals. So he came in with an infection. Okay, so when you see bone like this, we call this radiolucent. So this is healthy bone. This is representative of an infection. So conventional dentistry would say, yes, this needs to be dealt with. You can't leave that. That's an active infection. We need to do something. Now, knowing what I know, when I see a situation like this, I have a conversation with the patient and say, and this guy's got prostate cancer, okay? So the guy with the 11 root canals and the couple of implants, I'm thinking about his health. I'm saying, you know what? I'm taking this tooth out. You should let me take this one out too, because I have a feeling that tooth's not healthy either, even though it doesn't look infected. And so when I took the crowns off, the front one, the black one, is the tooth that conventional dentistry would say, you know what, that looks okay. So that's kind of the big shift. So this is him, just to show you, to remind you. And then these are those teeth. Sorry, my computer is just a little bit.
So it wasn't just me.
No, I think it's just, it's nervous. There it is. Okay. So the bottom over there, that's that tooth. So like these are diseased. And you know, I asked dentists, I'm like, yeah, I'm like, would you want that in your mouth? Like, you know? So the conversations a lot of the time in conventional dentistry goes to, oh, there's an infection. Let's do another root canal and get it to heal, right? And like there's this idea that we can turn, oh, okay. Yeah, there's this idea that we can take an unhealthy tooth like that and somehow turn it into a healthy tooth, which I think is a crazy idea.
Sorry, Julian. But that had root canal.
Yes,
So those
yeah,
nerves were dead. Everything was dead.
yes.
How did it get so that?
Because of,
Just bacteria underneath. And
yeah, like like you get a seal initially when you do it, but the mouth is a hostile environment, and these teeth are under incredible amount of force, and so they break down over time. The teeth become very brittle. So when you extract teeth, you really learn this lesson, because the root canal teeth are so much harder to get out because they just break. They just keep chipping away. They become so brittle because they're not vital, right? It's like anything in nature that dies, it decomposes over time, right? And that's what happens with teeth. And so, yeah, it probably was nicely done. It was probably sealed well, but over time, as the wear and tear happens, the seals don't become as good, and then bacteria can get inside and have a nice little party.
Julian,
Yeah,
can I add?
yeah, please.
The root canal tooth is a very complex network of structures that go from the inside. Go to the root canal picture. When you do a root canal, you're basically taking the trunk out of the tree. And you have paths that go outside the tooth to the periodontal ligament around the root. There's never any way you can disinfect that. Ever. Your immune system has to deal with that forever. So that tooth is always infected, whether it's symptomatic or not.
Yeah, they're porous. Like a tooth has all these like crazy amount of canals in them. Like you're looking at the main canals, and there's like thousands of accessory canals. And so it's like a sponge, and bacteria can get in easily. And now I don't go around saying like every root canal should be extracted. Like I take it on a case by case basis. Like, what do you think?
You have to give, it's called informed consent.
Yes.
And
Yeah.
we've got away from that.
Yeah.
You have to tell patients that root canal teeth can never be fully disinfected, and their immune system is going to be compromised, or is going to be dealing with that the whole time that it's in their mouth.
Right. So I have this conversation all the time with patients where their nerve is infected or dead or dying. The option is either they get a root canal to keep the tooth, or they have the tooth extracted. The talk I'm having with patients now is, look, if you aren't ready to have the tooth out and do an implant or whatever, you can do a root canal. Don't view it as a long-term solution. It's a short-term solution to buy you time. And then be aware that over the years, it's more and more likely to become infected. And without you noticing, it could be subclinical. It could be impacting your health, right? So that's kind of my informed consent now.
What about in baby teeth? So when children are having root canals and those baby teeth that are falling out, does that affect the adult tooth coming in after that?
So it's kind of a different situation. The short answer is usually those teeth aren't in long enough to actually be really detrimental. They often get infected and then we end up extracting them. But there's a problem. The problem with kids' teeth is that you have to maintain the space. If you take out the tooth, the space collapses and then you have like an orthodontic problem. So we're often saving baby teeth to keep them long enough while they're growing, so that the adult teeth can come in, versus if you take out a tooth too soon, the other teeth can collapse, and then when the adult tooth's trying to come in, there's no space for it, and then you get into like spacers and all these things. So sometimes if it's only going to be 2 or 3 years that they're going to keep that tooth, it's maybe still the best thing to do like a baby root canal. But
isn't that the same for kids with their adult teeth that you should do a root canal because you can't replace it with an implant?
you can't do implant. Yeah, like a 16-year-old, if they fall and break their front tooth or something, they're usually too young to have an implant because they're still growing. When you put an implant in, it won't move with the growing jaw. And so you can't really do implants until someone's done growing. So you might do a root canal to buy them time, right? And now the good thing is that the ceramic implants are so good that I feel good about putting one in a 20-year-old. I think there's a really good chance it could last them the rest of their life. Like mine, I have on my front tooth, I expect it to last the rest of my life. I couldn't say the same thing for titanium. So if a 18-year-old broke their front tooth, we're trying to keep that tooth 10, 15, 20 years so that by the time they get the implant, it has a chance of lasting them. Now with the ceramic implants, it really changes that conversation, and there's not a lot of reason to keep a root canal tooth. So this, yeah.
Sorry, I'm just not clear on technically what's going on. So when a 12-year-old or a 15-year-old they have a root canal because they've had some tooth infection
Yeah.
on some reason. What literally are they having? They're not getting implants. They're having the tooth extracted in its root. And then what's put in its place? Like technically I don't.
No, they're not having an extraction.
So what is a root canal?
So
What's the meaning of that?
So I'll show you in the next slide. So this is when we take the teeth out, you can either do a delayed approach where you take the teeth out and maybe do some bone grafting, wait for things to heal, and then after it heals, you can put implants in, or you can do it at the same time. Depends case by case. So this was a delayed approach. So we took the teeth out. We're using PRF. Is everyone familiar with PRF is? Where we draw blood, spin it in a centrifuge. So we're using their blood concentrates surgically as wound dressings, and that really enhances the healing. And then a few months later, go back in, put the implants in. To answer your question, so root canal, the outer shell of the tooth is still there. You go in, you drill a hole in the biting surface of the tooth, and then you go with these files and you file out the nerve and pulp. It's the pulp tissue, so it's the nervous tissue, the blood supply. If in a healthy tooth, if you drill into this, it bleeds. It's like a dog's nail. You ever cut a dog's nail and you go too far and then it bleeds? It's like that. So you go in with a file and you file out all of that vital tissue, and then you seal it up, and then you're left with the outer structure of the tooth, and the nerve and pulp and blood supply has been removed. Does that make sense? So like a kid,
They put a crown.
yeah, and then you cap it. So there's the final result. So you can see all the healthy bone around. These are the ceramic implants. So all the bone infection is all filled in with the patient's own natural regenerated bone. Next case here, this is Maria. So she's 60 years old. She's a dental hygienist in Toronto, and then she started coming to see me. So another one of these cases where just so many teeth have been root canal treated. So can you guys kind of tell now, when you see an x-ray like this, you can count how many of the teeth have root canals. So in her case, it's 1, 2, 3, 4, 5, 6, 7. And this is kind of typical of like the dental cycle. So someone who they just have dental problem after dental problem, and they've got cavities, and then the cavities lead to a toothache, and then the tooth breaks and they get a crown, and then they end up with the root canal. And this is very typical of just someone going through the dental journey, and just problem comes up, you fix it. Problem comes up, you fix it. And so after decades and decades of this, you end up with a situation like this. And then, fortunately today we can look at something like this, take a different approach, actually restore this person back to a place of better oral health, rather than just managing their decline, as I kind of alluded to at the beginning. So this will be a little bit fun to get into some symptoms here. So she had chronically inflamed knees and ankles, and she actually went to the ER and saw MDs, rheumatologists, internal medicine, and they diagnosed her with reactive arthritis. She had all the tests for autoimmune. They said it was negative. And I think you guys probably experience this a lot. These patients who allopathic medicine can't help, it's just antibiotics and steroids concurrently, right? There's like no solution.
And they didn't measure enough autoimmune markers. They
Yeah.
measured ANA, RF, maybe a few others.
Yeah.
We can measure almost 200 of them, and we can see the autoimmune activity. That reactive arthritis is
Right.
That's that prodromal autoimmune phase.
Yeah.
Probably from the mouth, right?
Right. So, she had swelling, weakness, restriction of movement. So she started seeing me in 2023. Here's another one of those situations where this one was infected, but now with the way I look at these things and someone with health issues, I'm trying to talk them into taking out, at least in the area we're working, take out the root canals. So this same thing, this looks good. Conventional dentistry would look at this and say, yeah, looks good. That tooth's fine. That's the one on the right. So it's like a necrotic, gangrenous, like it's the same thing. It's like, would you want that in your mouth, right? And so there's a guy in Portland, Oregon, who is a colleague of mine. He's done a lot of podcasts on these things. So every tooth he takes out with a root canal, he sends for some analysis, some bacterial analysis, and then he'll share it on social media and all that. So they always come back just loaded with bacteria. So back to Maria. This is what we did for her. So we took out all the root canal teeth, replaced them with ceramic implants. You can really see, like what you were mentioning before about when I took that implant crown off and the gum was really inflamed. What's amazing about the ceramic implants is no inflammation. So the material is called zirconia. I actually have some samples here to show you guys. There's titanium implants here and there's ceramic ones here, if you guys want to see what these things look like. We're just lucky by the grace of God that we have this material called zirconia that just doesn't trigger the immune system. The body sees it as neutral, and it doesn't trigger inflammation in the bodies. And it's white. So it's literally a miracle that this material exists, and we mine it out of the earth. And so zirconium on the periodic table is in the metals section. But when it takes the oxide form, it's zirconium dioxide, also known as zirconia, and it's no longer a metal. The same way, if you look at the periodic table, sodium, Na, is a metal, but when you have sodium chloride, you have salt. So when metals combine with other elements, they're no longer metals in some cases. I mean, you have alloys as well, but so that's the story with zirconia. It doesn't have the electrical conductivity, doesn't attract EMFs. So yeah, that's what's beautiful about this material. This is what convinced me to get one in my own mouth. Just no inflammation around the material. So that's kind of the gist of what we're doing, is we're just taking out diseased tissue, cleaning it out like I showed you, and trying to replace the teeth with the most biocompatible materials we have available today. There may come a time in the future where zirconia is no longer the best. Maybe we're regrowing teeth or something, but For now, this is the best that we have, and it's pretty amazing. Then, so you saw the implants are kind of at the gum level, and then when it comes time to restore them, we attach posts to them and we shape them like teeth, and then we make the crowns to cement over top. This is my tooth. This shows it a little bit better. This is a one-piece implant, so we also can do situations where we take a tooth out, put an implant in, and attach a tooth to it all the same day. So this is what we're doing now for teeth in the smile zone. So patients never have to go with a tooth missing. They don't have to wear some flipper removable thing. So that just kind of nicely illustrates. You can see again, like look at the gums. There's no inflammation. The other cool thing is the gums connect to the zirconia. So not only does the bone integrate with it, the gum tissue forms a junction, and it's a barrier. We were talking about leaky gum. So that's portions of the gums that are an entry point for bacteria. So the gums actually seal around the implant, and there's no pathway in for bacteria. So if I take my like air jet thing and I blow air, like forced air into it, the gum doesn't peel away from the implant, which it does when you use metals. So when you use a titanium implant, there's a pocket that goes from the outer part of the gum down into the bone level where the implant is, and it's always a potential entryway for bacteria. That's like the leaky gum concept. So when you have junctions in your mouth that aren't tight, it's the same problem you can have with the gut, where things that shouldn't be getting in are getting in. It's the same thing we have in the mouth. So Maria, so she said, I know, so this is funny. She didn't actually come to me for her health. I got into this stuff after I started seeing her, and then I offered her the type of treatment I was doing, and she went with it. Then a few weeks ago, or like a month ago, I asked her, I was like, so I want to ask you, like, have you noticed any difference in how you feel and all that? And she had an epiphany, and she's like, oh yeah, all my arthritis is gone. And yeah, and so she said, I noticed gradual improvement as the months passed after the lower treatment. After the upper treatment, I am now completely without swelling on both ankles and knees. I no longer go slowly, cautiously up and down the stairs. I can now cross my legs when sitting on the floor, and I'm looking forward to wearing my summer sandals with a smile. I haven't experienced any reoccurrence. So that's pretty cool. Like, obviously everything's super interconnected. Yeah.
Yeah, so I think what we're gonna hopefully be able to do is do a full metabolic inflammatory immune panel before, and then we can do the full surgical with all the medical modalities and do them after. And then if we have the objective data before and after, we can publish this.
Totally. Yeah. Yeah. And then I can get my license taken for helping people.
Well, that wasn't my destination there.
So you help people. You can't do that. Keep them sick. But no, that'd be awesome. Totally. Yeah, because that's like when you're in this world that I'm in, you face so much skepticism. And yeah, there's a lot of good data, but there needs to be more. And it would be really cool to be able to put together some very compelling case studies like that. Yeah.
Journals that we can directly connect with.
Nice.
Pretty easily get these published, peer reviewed and some non-peer reviewed.
Okay. Perfect. Okay. Next topic.
Move on.
Yeah. Yeah.
So that individual that had a root canal that was infected.
Yeah.
We saw that translucency. You remove the tooth, you clean the bone.
Yeah.
But I think you said you put the implant the same day and close it out. Isn't that a risk though, that some bacteria gets trapped and creates a foci or saponification or something?
You have to make so in her case,
It was not her, it was a gentleman previously.
oh, Larry.
I think you said you did that the same day.
Yeah. It all depends on how well you're able to clean. So if you have like a really severe infection, you might make a clinical judgment call and say, yeah, I can't put an implant in here. that being said, you can usually clean it really well, and like you can visualize the healthy bone and you can see the blood coming. We do a few other things, like I've been doing some IV antibiotics, and then the PRF gets infused with antibiotics. So you're kind of putting some insurance policy in there. We use ozone. So once you have everything cleaned out, you irrigate it with ozone gas. So you're kind of doing a few different things to cover your bases. And then ultimately you make a judgment call about whether or not you're comfortable putting the implant in there. But yeah, I was going to show you Maria's here. The one tooth I actually didn't do the implant right away, the one with the bad infection. Where am I? Did I go? Yeah. I did this one in 2 steps. Today I would probably do it all in one. I'm getting a lot more comfortable with that, and the results have been really good. I feel very good about being able to clean that thoroughly and then do it in one surgery. It's a big advantage to the patient if you can do it all in once, because otherwise you have to wait 4 months to heal before you can put the implant, and then wait another 4 months before you can put the tooth in. And then if anything goes wrong in that time, like it could be a year before the patient gets their teeth. So if you can do it in 4 months, it's not, 4 months is easy. Like they don't really have to suffer that much.
And if somebody has a
Titanium? Yeah.
Titanic,
Yeah.
implant, you would do that in one session. You clean it, you take
Usually.
Yeah.
Yeah. More than 90% of the time. Okay, so who here has heard of cavitations before? So like maybe half of you guys? All right, and do you know much about it, or?
They don't exist in Ontario.
Right, yeah, true. Yeah, that's true. Yeah. I'll just move on. Yeah, yeah. All right, so this is a fun one. So the layman's term is cavitation. It's kind of being decided on by this group of doctors that I'm associated with. That's the term we're going to move forward with. There's a few other names for this that you may have come across or you may come across. So the other one is fatty degenerative osteonecrotic jawbone, FDOJ. And then the other one is NICO. That's the old term. You may have come across that if you've kind of been in this area for a while. Neuralgia-inducing cavitational osteonecrosis. They kind of got away from that because some of these don't have an associated neuralgia, right? So some of them do, but some of them don't. Some of them are totally subclinical. So when you extract a tooth is in a socket, right? So it's surrounded by jawbone. You take a tooth out, now you have this socket of like a void in the bone. The way it's supposed to happen is your body produces blood, and then blood eventually it triggers the cascade to form new bone and trigger osteoblasts. So ideally you have the socket and it fills in completely with the patient's own bone. Now the reality is in our modern world, like this is connected to the presentation from before of why people are so unhealthy. There's all these factors that combine to produce an insufficient healing result. And then those sockets don't completely heal. They just they heal over top on the gum, but the bone inside doesn't heal. And then the patient is left with this chronic infection in their jawbone forever. And they're just, this is actually probably, like you mentioned this new condition that you're seeing. It's kind of,
Metabolic endotoxemia.
yeah, so, on the same line as that, this is probably one of the #1 silent epidemics of humanity that is completely ignored largely by the medical and dental profession. So we get situations like this where you see and I'm showing you guys these kind of x-rays because these are actually pretty easy to look at, and as a doctor, if you learn a few things, like this actually might be helpful if your patients have one of these already. If they give you a copy, you can actually look at it and you might see something, or at least like have an idea, and then you can ask one of us. But all these areas here where you see the radiolucent bone, and there's one over there too, this is all situations like that where teeth were extracted and the bone didn't heal completely. So let me just go, yeah. So there's one, there's one, there's one, there's one. The funny thing is, this was a conversation in our like dentist group chat where we have the dental specialists in there too. So one of the general dentists shared this x-ray with the specialist, with the oral surgeon. He said, hey docs, I have this new patient in the chair and this pan was just taken, 68-year-old patient. Can I get your opinions on the bone in these areas as well as the canine area? So the oral surgeon said, hey, it doesn't look too suspicious, to be honest. 4-8 is just incomplete healing that can occur sometimes, which is true, but the thing is, it's a problem. But the profession doesn't it's just, yeah, it didn't heal properly. The other one, blah, blah, blah. Anyway, so here's a little bit of what we see going on biochemically, and you can actually test for some of these things. So have you guys heard of RANTES? I think it might be a European term, but there's these inflammatory markers that are elevated when a patient has this condition. So it can be tested for. I think it's not an easy test to do. But here's a little video going through a bit of
For
this.
an FDOJ, first of all, what is an FDOJ?
Is it too loud or is it okay?
Degenerative osteonecrosis of the jawbone. Often we find it in the wisdom tooth area when the wisdom tooth was pulled and the bone couldn't heal correctly. We also find it around root carotid teeth, infected teeth, and also titanium implants. The problem with the FDOJ is the systemic effects that it has, the negative effects on our systemic health that I will explain shortly in a second. Here you see a histological picture of an FDOJ. It was from a patient that had a trigeminous neuralgia all his life, suffered a lot. When he died, he asked the doctors to get a probe of this area because he thought something is there and nobody believed him. And when they had a look at it, they could see that the bone was degenerated in this area and that this was probably the cause for his trigeminous neuralgia. We have a problem with these areas. They have a constant release of inflammatory mediators, and that is RANTES. RANTES is one cytokine that is constantly 24 hours, 7 days a week high in these areas. We know that from analysis of the multiplex analysis from laboratories. And what does RANTES? It is a normal cytokine that everybody has in his body, and it goes up if you have a wound, an open wound, for example. It is a chemotactical mediator, so it triggers the immune system to bring lymphocytes, granulocytes to heal this wound. Once the wound is healed, it goes down again. So it is a marker for a wound, for a chronic wound. In this case, when we have a constant release of RANTES, that means the body gets a constant information that we have a wound and is constantly sending inflammatory markers or healing cells to this area. So the immune system is constantly triggered by this high RANTES. And we know from the medical, from many, over 10,000 medical studies, that higher RANTES levels in the blood are related to diseases like MS, arteriosclerosis, arthroid rheumatitis, also autoimmune diseases, depression, chronic fatigue syndrome, cancer, many diseases, and still the medical field does not know where this higher RANTES level come from. We know, at least in these jawbone areas, and especially for patients who have these diseases, we need to look at these jawbone areas and clean those so that we don't have these constant Rantes levels in these patients. Also, the fibroblast growth factor is elevated. So this is a constant release and causes these diseases that I just named and can promote them. Here you see a surgical protocol of an upper osteonecrosis. You see that you often have a fatty blood or yellow fatty solution that you need to clean.
So see the fat droplets? So this is what we see. It's you open it up and just oil comes out.
And then you have to look or have to make sure that there are no fatty eyes on this blood anymore. That's a sign that you clean it correctly. It's very important in the tuberous area to really clean everything and also remove the palatal bone, the buccal and distal bone so that you don't have a recurrent nico. We also disinfect the area with ozone and we supply the area with blood concentrates, PRF, so that we have an accelerated wound healing and a better bone regeneration. And then it's important to make a tight suture to cut out over excessive tissue or use a laser for it, whatever you prefer, and really have a tight gingiva around your last tooth so that you don't have an infiltration or penetration of bacteria around this tooth. And that helps our patient to prevent or take a part in the prevention of these diseases, or also help them when they have these diseases that therapies work better. This is the multiplex.
So that's the fat. That's the same picture I had on the start.
And you see that the Rantes level, would be a normal Rantes level in a normal healthy bone. This is the Rantes level they found in over 128 probes of patients. It is 35-fold higher than usually, with over 5,218 picograms. What we also see is that this is elevated. It's the interleukin-1 receptor antagonist. Interleukin-1 is an acute cytokine. That means it induces an acute inflammation with the reaction of an edema, of swelling, of pain, of heating up of the area. So this interleukin-1 is depressed. And that shows us, or that's why patients often don't feel pain. Some have a chronic trigeminal neuralgia, but most patients, it's no acute inflammation, it's silent chronic inflammation, because the acute inflammatory markers are depressed. Also, we have very low level of interleukin 6 and 8, which are also acute inflammatory markers. And whenever a patient asks you, why don't I have pain, why don't I feel it? Yeah, the acute inflammatory markers are depressed down, and the chronic markers are high. It's kind of like a periodontitis. Patients don't feel pain, but their body, their bone resorbs, and their teeth get loose, and it's not a painful disease, and it's the same with our FDOJs.
So that last part's for you. I know you like your markers on your. Yeah.
Well, I was going to go that because it doesn't look very specific, like what Rantes stands for, regulated and normal T cells expressed and secreted. That's not like something specific. So how is that tested? Like what's being tested there? That's not an individual marker. Rantes is like a group of markers. Do you see the
What's the acronym?
Rantes.
No, what is it?
What does it stand for again?
It says regulated and normal T cells expressed and secreted. That's what it stands for.
Oh.
So what are you testing?
We don't test yet.
She's like testing that in Europe. It means something.
I don't even know if they test it much in Europe. It's a study she's referring to where they did it. They did probes on these. So yeah, I don't know the answer.
So we need that study to know what those markers.
Yeah, it's there. It's see the. Anyway, we can revisit it for sure. Okay, one more quick video here. This is the guy I trained with in Germany.
How my health for my cavitations on the right side. I had to laugh during the surgery because my chronic back pain just disappeared. And I was asking my surgeon, is this even possible? And yes, it was, because it never came back. Before the surgery, I was already having shaky hands and I felt like I had Parkinson's every morning, like I was drinking 3 cups of strong coffee. This nervousness also went away for good after surgery. My skin was still bad though. About 5 days after my second surgery, the left side, my skin issues started to disappear, and within the next 2 weeks I had developed the skin I was always dreaming of, and my whole back pain, which was actually referred pain from the chronic inflammation in my small intestine, which is always connected to the wisdom teeth cavitations, this was also gone.
So now we get into talking about the meridians a little bit. Are you guys familiar with this? So this is one possible way to explain these connections from the mouth to other parts of the body. So this is what we use. So we'll have a patient in, we'll take their panoramic x-ray that we have, we'll circle the areas of concern, and then we'll correlate it to their teeth and kind of give them this to do a self-study to be like, hey, you might be able to correlate some of your issues that you experience to somewhere in your mouth. So this is a nice little tool that we can use. There's also neural therapy where we can give an anesthetic injection adjacent to the tooth with the problem or implant or infection. And then you get a really good idea if your treatment is going to help their condition, because they can experience, like, let's say they have knee pain or something. You do the neural therapy, and then for the next 12 to 24 hours, their knee will have gotten better. And then you have a good proof of concept where, it's a test to see, hey, do we think this surgery might help you? So that's something that can be done. Yeah.
I use the biomeridian testing, and I can actually test each tooth to find the energetic quality in each tooth.
Nice.
The ones that are usually problematic are the ones that have the most work that
Yeah.
needs to be done.
What's it? There's a few different names for that kind of thing.
Well, electrodermal screening.
Yeah.
This one in particular is actually a little more concise.
Yeah.
Because you're checking all the different meridians on the body as opposed to like beta testing using one point exactly like
Yeah.
that. But if you're doing a full body assessment, you're using fingers of toes, right? So,
Right.
but in this case, you're checking each tooth individually.
Cool. Yeah, I really am interested in that side of things. That, like, is that kind of like ART too, or no? Like,
No, you're using a small amount of a stress frequency
Yeah.
to check and see if the body can conduct or
okay.
will resist the capacity.
Wow. Yeah, I'm excited to see that with you. Are you bringing that when you come? Okay, cool. There's a study here too at the bottom of this, of the guys that mapped this system out using electroacupuncture. So there is some science behind it. I was very skeptical of all this stuff when I first learned about it, and then after seeing the connections, like, really kind of makes you a believer. So this is a patient of mine. You can see where my mouse pointer is. There's the poorly formed bone. So can you guys all see that? In the upper, like up here. So the way we access these is we remove the cortical plate toward the outside of the mouth. The reason why the flap is so big here is because we were doing 3 implants for her at the same time as well. This is the plate of cortical bone, and you can see the fatty deposits just right on the underside of that roof. And you shouldn't have fat in your jawbone. So it's a really good sign that, like, something that's shouldn't be there is there. We have fat in other bones, like in the form of bone marrow, but there's no bone marrow chamber in the jawbone. So when there's fat, it's indicative of some kind of pathosis. So this is the patient. So you go in, you remove the bone, you go in, and it doesn't take much to just scoop the bad stuff out of there, and you're left with this hole. And so that's what you're looking at there. I've already cleaned that out, and there's this just giant hole in her jawbone. So this patient's name is Carol, and I did a little interview with her. She had some incredible healing. She had a lot of joint inflammation. She talks about this like rope that she had that she could feel down the whole right side of her body that would be like this tightness, and it all went away. She lost like 5 pounds of retained fluid, and all her joints got better and everything. It was pretty wild. So if you're interested in that, you just search that on YouTube, and it's like a 12-minute little conversation I had with her. She was one of the first ones that I experienced like these remarkable healing experience with. So talking about why this problem happens, of why the bone doesn't form properly in a tooth extraction site, I kind of list all the things that I can come up with here. It's kind of pointing to the same idea we're talking before of like, what are all these environmental factors that are leading to the poor health? So there's mineral deficiency of the food and like the way the soils are depleted. There's just stress, there's pollution, there's, vitamin, mineral, nutrient deficiency. So vitamin D is a really big part of our protocol. So we always have patients get their vitamin D tested before any surgical intervention. So that can be like a real low-hanging fruit of a reason why someone doesn't heal and regenerate bone properly. Because as you guys know, vitamin D is responsible for calcium uptake. There's that whole thing about people thinking they need to take calcium for their bones, but it's really not the truth, right? It's whether or not the calcium is being absorbed, and then is it staying in the bloodstream or is it being deposited in the bones, which is dependent on D3, K2, magnesium, all those fun things, right? So yeah, exactly. So I even have that here, the sympathetic or the neurological state. So part of our protocol as well is really emphasizing after surgery, the patient needs to rest like for 3 days minimum. You're doing nothing. You don't even go for a walk. You're like literally in bed or just relaxing at home. Try to limit the screens and the phones and the EMFs and everything. Get your nervous system in a place that it can focus on healing. A lot of people have surgery and they go back to work the next day, or they go to the gym, and it's like the total wrong thing, because your body can only deal with so much. It's the same reason why you shouldn't eat a meal and then go for a jog, because your body can't focus on digestion. Same thing with healing from surgery. So our approach is really about focusing on how do we prepare this person's body for surgery as well as possible and set them up to heal properly. And this is what allopathic medicine and conventional dentistry is missing. We just book the surgery. You say, you come next Wednesday, we're going to do it, and then you'll have some swelling after, maybe eat a popsicle or something like that to help with that. None of these factors are paid attention to. And so, if anyone here, for example, let's say you have kids and let's say they need to have their wisdom teeth taken out. These are some of the things that they can pay attention to before having the surgery, and they should heal okay. I mean, there's things that can be done during the surgery too that help, like using the ultrasonic to clean, using ozone, using the PRF. These things all help, but even still, you can really improve your healing outcomes just by some of these basics. Okay, this is Carol. She's 35. She had a traumatic child delivery April 2020. Her face went numb on the right side. She had an MRI. Neurologists revealed lesions on the brain. They diagnosed her with MS. December 2024, numbing from the chest to her feet and hands. They took a new MRI, showed 2 new lesions. They offered her steroids and immune suppressants, but she refused them. She got on like a health journey and made a lot of lifestyle changes. She was able to get around 60% better from December to March. We did her surgery at the beginning of March. She found me from Connecticut, and she drove 7 hours to come see me. She also had this vibration when she looks down. She felt this like vibration sensation. She did the research on her own, found out about cavitations, figured it could be something to help her on her journey, to help her get better. This is her scan. So she's got the 4 wisdom tooth areas where her wisdom teeth were extracted. They didn't heal properly. And so in the scan here, this is the 3D cone beam CT scan, so CBCT, that's what we call it. where you can, in 3 dimensions, scroll through someone's jaw into 3 different planes. And so you can see the poorly formed bone back here, and there's some up there, not as obvious on the top. So there's more, that's the other side. Okay, so that's what we're treating. This was her, okay? So that's the piece of bone I removed to get into one of the lower cavitation sites. And look at the fat that's deposited in there. So there was so much stuff that I took out of her. So she had a crazy experience while we were in the chair. So I'm working on her. And she starts doing this with her hand. And I'm like, are you okay? And she's like, yeah, my hand just went numb. And she had had partial numbness since December. So her hands hadn't felt normal. Then I'm doing the other side went numb. Then after about 30 minutes, both of her hands went totally normal for the first time since December. And then I saw her the next day, hands are normal. I've followed up with her every month since March. And I'll share it with you. But so she said, I heard stories of people having certain experiences during the procedure, but I honestly didn't believe that I would. At one point during the surgery, my right hand and arm up to my elbow suddenly went completely numb. Then moments later, the other hand went numb as well. About 30 minutes later, I was able to feel both hands normally for the first time since December. Within 4 weeks, I experienced 100% improvement in my hands. So just to sum everything up, so December was her absolute lowest point. Like I said, can you rate out of 100 how you were at different points in time? So she said worst possible rating December. By the time we did it in March, she was hands 60%, the vibration 40%, and then April, 1 month after the surgery, hands at 90%, 95%, and the vibration 85 to 90%. So this is my most remarkable outcome that I've had so far, where like literally her MS symptoms are almost completely gone. Okay, now this is Tracy. So now you guys have been through some of this stuff. So let's look at this one together. So what do you guys see? Not the dentist. Yeah. Okay, that's what I kind of want you to know. So this patient found out about biological dentistry, came to me. The way I find most of these patients is that guy I showed you, Dr. Dominic, the one talking about his back pain. He's got a huge social media presence. He's done all the top health podcasts and everything. So he's kind of created this movement. And so people will hear him on a podcast or see him on Instagram. Then they go to him. He's got a directory of all the dentists he's trained. And then they reach out to me because I'm on his list, right? So she came from him. Like probably 80% of my patients come from him. It's pretty crazy. So she wanted her root canals out. So I look at her and I see all the problems that she's there for and all the things we've been talking about. Okay, so she's got metals on other teeth. She's got the lingual bar. She's got, did I list her health problems? Not yet. Okay, so this is her. And this is where Dr. Clinton comes in, and then why I asked him to be here, because I've gotten a whole other type of education from him. So if you look at this patient's posture, she's totally out of joint. So look at her shoulders. One shoulder sits lower than the other. She's got the really bad anterior head carriage. And her symptoms, she's got intense stabbing electrical type pain in the left facial area requiring 2 medications. So carbamazepine and gabapentin to be able to eat. T3s and tramadol did absolutely nothing. Triggered by brushing teeth, eating, cold air, tension in the neck and shoulders, causing headaches, facial skin highly sensitive to touch. For example, wiping off makeup, putting on cream would trigger intense pain. So what do you guys think the treatment plan is here? Yeah. Okay.
Is that metal in every tooth, or is that the lingual bar that you're seeing? Like,
You're seeing the lingual bar, and she's got crowns. Like people get like aesthetic cosmetic work done to make their smile nicer. So you're seeing all these crowns. Those are ceramic crowns, so there's no metals there. There's metals on the other teeth because some crowns have a metal undershell and ceramic over top. So that's like that, right? So they've had to grind through the porcelain to fix her bite. So the answer is I didn't do any treatment on her because I recognized through my education with Dr. Clinton that I could make this patient worse. So if I go and I take out these teeth, she's already missing all her molars on her right side. She has no bite here. I'm noticing she's got all this facial pain and all these symptoms. Her posture is totally out of whack. If I go and take out 4 more teeth over there, I risk making her even worse and putting her into even more of, she's already in crisis mode. She's not compensating well at all. She's suffering, and I could make her even worse by pulling her root canals. So, and the reason is she doesn't have a stable bite already. So the way the teeth come together is very important in giving neurological, neuromuscular feedback to the whole physiological system. And when your bite is off, it can really throw off everything. So I have to be careful in screening these patients. So I referred her to this guy. He was invited tonight, but I guess he couldn't make it. His name's Dr. Marty Frankel. He's a colleague of Dr. Clinton, and they did a lot of the same neuromuscular dentistry training. So he's in Toronto. So I've been sending, what's that? Frankel. So I've been sending, this is Kelly, my wife. So Kelly has seen him too because she's got issues. And yeah, so I went and so there's this whole other side of dentistry where you use electrodes and you measure the neuromuscular system. So they're each electrode is measuring the muscle activity of the different muscles of mastication. And then I'll let Dr. Clinton speak on this a little bit, but it gets out of balance and then it just throws the whole system off, right? So Kelly got one of these appliances made, and it's called an orthotic. No, this is not Kelly. Yeah, but yeah, but these appliances get made in the correct position where the muscles are the most relaxed and balanced, and you use the instrumentation to measure the muscle activity, and then you find the right bite for the patient, and then you make them this type of device to wear, and it balances the bite. And then I have this chart here that kind of like people, everyone's gotten a night guard probably before. If you've seen a dentist, they've sold you a night guard, right? And night guards are just like this upper left here. They just arbitrarily open the teeth, put the piece of plastic in there, and they have no measurements of the muscles, and they don't know anything that's going on of what they've done to that person's neuromuscular system, and it could throw it totally out of whack. So like these are the readings over here, and I'll let Bob kind of comment on this, but
I'll ask a question about functional medicine people. How many points of contact does each vertebrae have? It's an expert here. I think we need a chiropractor. Like every vertebrae is a tripod, right? It's got lateral processes, spinous process. How many points of contact does the head have? Look at the head as a specialized vertebrae. C1 has how many contacts with the skull? 2. It rocks, right? What's the third point? The teeth. So when you see a patient like this and they've got all their teeth restored, that third point of contact is distorting that tripod. You distort that tripod, and you distort the whole neurology down the whole system. Not only the neurology in the spine. I have a background, I have a master's in neurophysiology, but you distort every cranial nerve that comes out of that skull. And if that's not balanced, you're going to distort the cranium. I have osteopathic background too. You're going to distort where the nerves come out of the skull. You're going to compress them, and you're going to all sorts of symptoms. I can talk at length on this. The point being is that when you're messing around with the occlusion, you see someone that has a lot of restorative work done, that whole system's out of whack. And the only way to get that person back between the goalposts is to try to calm down their neurology. And what we're doing here is you want to make that tripod so things are balanced. If you have an unbalanced tripod and you throw a piece of plastic in there, you don't know what the hell you're doing. You have no where that bite's going, and there's no way that you can prove. If you can measure something, it's a fact. If you can't, it's an opinion. And most night guards that I measure, like the one on the right, we're measuring 8 muscles.
Do you mean this one?
On the first half of that, the right half
Yeah.
of that, is where they stand in a relaxed situation with their teeth slightly apart. And then we put the night guard in, and the muscle activity is really distorted. You'll see a lot of distortion. You'll get more torque. So the goal is over on the left here, over on
The right.
on the left, where when the patient's just sitting, even when they put that orthotic in there, the muscles just calm down all on their own. And when they bring their teeth together, slightly touching the orthotic, there should be no change in muscle activity. You should have balanced the muscles, because now you've balanced the torque system. So touching anyone with Julian does a lot of back teeth, the molars. The molars are the support teeth. And I see this all the time where those teeth are treated and it just distorts that tripod. And it creates all kinds of fibromyalgia, chronic fatigue, head, neck, and facial pain disorders. And it's just another element of biological dentistry that one of the major factor that you have to consider when you're assessing these patients.
What about something like Invisalign? Does that also create
It's over here.
Okay, so these guys probably take care of basically when people have orthodontics that leave them with migraines and chronic headaches. This is the way to basically balance them out.
This is the way to assess them, to see where they're at. Most of my chronic head, neck, and facial pain patients were orthodontists. Orthodontists are great at making teeth aligned and straight. They're pros at that. But they just don't know where to put the bite. And there are other orthodontists out there, Michael Mew, and a couple from UK, and then there's a few orthodontists out there that are actually looking at balancing the bite. When it comes right down to it, when you straighten your teeth, what do they put in after they straighten their teeth? Maybe they put retainers.
Yeah,
They're retaining your teeth in a torqued, unstable position. Teeth should be put into positions that are stable, that are neuromuscularly and balanced physiologically, so that everything's balanced. They should be able to stay there on their own without retainers.
So what about kids in sports, mouth guards? I mean,
there's a whole story there too. I got it. Yeah.
part two. We'll do part two.
So
Yeah, there's actually an opera out there that made the news. A lot of Olympic athletes were using it, Pure Power Mouth Guard. They were using this technology. We were using this technology to find the optimal position for the jaw, increase strength, increase flexibility, decrease injuries. Because now you've got a system that's not torqued, but a system that's more flexible.
well, they had
Sorry? That was creates the same problem.
So my kids now, both of them had work done.
Yeah.
And I have remorse. What if it's not? What if the bite is not balanced? And so would you be able to take somebody that has orthodontic work and fix that? Or?
For 20 years, almost every dental assistant that came into my office, after about 6 months or a year working with me, they'd sit me down and say, fix me. I had orthodontics once, twice, and we would tweak their system so it was balanced. Yeah, you can do
So
that.
you can,
Yeah.
do you use
I'm trying to get him to come work at our. He comes like one Monday every 2 months to see my patients, and trying to coerce him into more. But
Well, I really caution you about treating Tracy because
yeah.
that's a classic case. You just don't want to.
So anyway, Tracy, so this is her. So I followed up there. I didn't take out any teeth. She said, I have had my orthotic in for about a month now, and I have gone off my trigeminal neuralgia medication. It's such a relief for the chronic pain to be gone. So it's just a cool thing to share that these things are complicated and there's not one size fits all solutions. It does, we might move to do some of the surgical work on her, but we had to get her somewhere where she's more stable, that she could even be able to tolerate the surgical intervention. Okay, so we're just wrapping up here. So in summary, metals, root canals, poorly healed extraction sites, bite imbalances can be major contributors to a patient's systemic condition. With accurate diagnosis and the right treatment protocols, we can predictively help our patients reduce their toxic load and facilitate systemic healing. This is where I need your help, as I mentioned earlier. So for you guys, this kind of was mentioned before, like things that you can think about adding to your new patient intake questionnaires to try to identify some of these things that could be going on with your patient. So do you have any metals in your mouth? Do you have any root canals? Have you had your wisdom teeth extracted? Have you had orthodontic treatment? So that's a big one. If it's almost like across the board that the orthodontic treatment is leading to some kind of cranial structural problem where, and especially the retainers that are binding up the whole system and not allowing the bones to move physiologically. And then, do you have any issues with your bite? So you can just sometimes ask that question and be like, oh yeah, my bite is brutal. And it's a big red flag. Yeah.
So you recommend removing those lingual retainers?
Generally, yes. The patient's got to accept the consequence that maybe their teeth will shift, and they could wear something at night, like a thin, like removable retainer they wear at night to prevent their teeth from moving. But like, I don't know, Rob, you got yours off. Like, how do you feel?
The neuromuscular dentist?
Sorry.
Any dentist in
I didn't notice. I didn't notice a huge difference.
Yeah.
But I wear
But-
a guard once every 2 weeks
Okay.
just to keep them in the same place.
Yeah.
But that's it. I can floss.
But some of us start doing this stuff proactively, right? Like even me, I had my tooth extracted. There's a link on the thing there that I put up here, but of my whole journey going through all this stuff, and I made a video about getting my tooth surgery done. But yeah, I like electively had my front tooth extracted, kind of preventatively, honestly, right? Yeah.
When they put this, I kind of forgot to ask you this, the SCS ceramic implant,
Yeah.
do they ask you about a tongue thrust pattern? Like, do you?
No.
They didn't ask. Okay.
Yeah.
I'm curious.
Yeah.
Sometimes
That can cause a problem. Yeah.
Yeah.
Yeah. So some other questions for you guys too. Do you have bleeding gums? That's the leaky gum thing. Did you have a lot of cavities or fillings as a child? Did you have teeth extracted for braces? So that's another huge problem. The way orthodontics was done in the past, they would pull teeth out to make room and then pull everything back. And turns out this ends up causing like a lot of sleep apnea, for example, because you've made the mouth smaller, pushed the tongue back, and now you have an airway restriction, upper airway resistance syndrome that's been caused by the orthodontics, right? So do you have head, neck, facial pain, TMD? That's temporomandibular disorder. Clenching, grinding at night. So clenching, grinding, snoring, they're all signs of sleep apnea. So this is another big area of dentistry. It's actually finally made its way into like mainstream dentistry, is now paying a lot of attention to this sleep apnea connection. So that's good. And then there's also like the whole birth story thing. Breastfeeding is really important for proper facial jaw development. So a lot of the patients that we see with these breathing issues down the line, turns out they weren't breastfed. They never got that proper stimulation to encourage the forward growth of the jaws. The other big one is soft food. So all the baby foods, the you know, those squeezy pouches that everyone gives their kids now, it's like recipe for underdeveloped jaws. You don't chew, you just mush the food with your tongue and swallow. You don't develop the right swallowing reflex. It's like huge problem. So, you know, we tell families like no baby food. They breastfeed if you can, which is great, and then move on to solid foods. There's that whole baby-led weaning thing. That's kind of, to me, the best way to go. Alex knows a lot more about this than me, but yeah. So anyway, a little bit about our clinic. So I've got two different kind of facets of the clinic. So there's the Canadian Biohealth Center. This is our Optimal Health Lounge that we're building in the basement. I'm partnering with Dr. Arsenault to do IV vitamin infusions in conjunction with the surgical interventions. So patients are coming in for surgery. They'll go to the lounge downstairs and get some nice treatments to support their system going into the surgery and then also post-surgically. And then there's Terrain Dental Wellness. That's our family dentistry, biological dentistry clinic. My surgical stuff falls under there, and also our general family dentistry with these dentists here working with me. So that's us, and that's it. Thank you, everybody. Yeah. So I don't know, it's 8:37. We don't have to rush out of here, but if anyone's got to go, no problem. But there's also some healthy desserts over there. But yeah, I wouldn't mind if we want to continue discussion. That's totally cool.